All right, a big thank you to Professor Shivarama Varambali for a fabulous talk all about the lifestyle, the healthy lifestyle for a healthy mind. And I cannot stress more when it comes to yoga. Each and every one of us must adopt it because it's for the well-being of everybody, including yourself. You heal yourself and you heal others. A big thank you to our platinum sponsor, Vakrangi, that has sponsored the previous session and is also sponsoring this particular session. So once again, a big thank you to our platinum sponsor, Vakrangi. With that being said, ladies and gentlemen, this particular session is truly going to be illuminating and enlightening. Why? Because it's a good fortune for we have not an encyclopedia, but the entire library when it comes to mental health joining us. He can write the holy Bible of mental health all by himself. That is how much he has in store in his brain, and he's just going to try and share some of it through share screen with each and every one of us. With that being said, this particular session, the topic is burnout in medical students and doctors, which is very much quite a prominent thing. So the speaker for this session is Professor Dinesh Bhugra, who is the past president, World Psychiatric Association and British Medical Association. And I would also like to invite Mr. Deepak Yadav, Joint Secretary, Mental Health Foundation India, to take this session forward. Mr. Deepak Yadav, who is a social scientist by training, working in the area of substance abuse since the last 30 years with National Drug Dependence Treatment Center, AIMS. He is WHO certified trainer in assist-linked brief intervention and has developed manuals of brief intervention, psychological intervention of substance use, and has been meditating since the past 14 to 15 years. और इनकी जो कहते हैं इनके ऑरा से देख के लगता ही है कि वो पॉजिटिविटी की रेस हमारी तरफ आ रही है. And Professor Dinesh, I'm truly excited to hear what you have to say. So first and foremost, let's have a huge round of applause for both the gentlemen, and welcome to both of you. Deepak sir, over to you.
Thank you for a very generous background and introduction, and I'm immensely honored to welcome for this session somebody who's a master in his field, especially when it comes to mental health and all that. It is my again my privilege to introduce Dr. Dinesh Bhugra, who is a professor of mental health and mental health and diversity at the Institute of Psychiatry at King's College, London. He is an honorary consultant psychiatrist in the South London and Maudsley NHS Foundation Trust, and is former president of the Royal College of Psychiatrists. He is the past president of the World Psychiatric Association and the past president of the British Medical Association. Dr. Bhugra became chair of the Mental Health Foundation in the year 2011 and was awarded his CBE in the year 2012 for the services of psychiatry, following 3 years as a president of Royal College of Psychiatrists. His research interest includes topics across social and public health psychiatry, cross-cultural psychiatry, migrant mental health, professionalism in psychiatry, depression, psychosexual medicine, service provision, and decision making. That's a huge contribution to the field of mental health, and I am very sure that all the participants will be immensely benefited by having you here to deliberate upon one of the very leading issue among all the professionals and medical professionals in general, and that is the issue of burnout. So once again, I take your permission, and with your permission, I invite you to start your deliberations, sir.
Thank you very much. It's a real pleasure to be joining you. Wish we could meet in person, but this is as good as it gets in these days. I'm really delighted to be talking about burnout in medical students and doctors for a number of reasons. I came to trying to understand burnout relatively recently, only in about the last 10 years or so. And that has meant that what I'm going to do over the next 40 minutes or so is three things. One, I'm going to talk a bit about burnout, definitions, what causes it. And secondly, going to present you some data on the rates of burnout and both among doctors and medical students. And one of the frightening things is you will discover that the rates are incredibly high. And I'm going to be initially presenting data from 12 countries and then follow it up from data from another 12 countries. So it's a global problem, not unique to any particular country. And lastly, I'm going to be talking a bit about how do you look after yourself to avoid burnout. And, we already heard about yoga and we've heard about meditation. So that's one strategy. And you'll be hearing from Dr. Sarah Eager immediately after me, and she's going to be talking about looking after your mental health and well-being. So burnout is related to things that happen to us in our jobs. So situations or events that put pressure on us and how we respond, what our reaction is to those stressors. And it's a pervasive and debilitating state that results from an unsustainable period of overwhelming stress. Now, it's not unique to medical professionals, but there are specific issues. And as we go through some of the causation, it'll become very clear as to what those factors may be. It is a component, three things. One is exhaustion, which is physical, emotional, and mental exhaustion, to do with situations which are emotionally demanding and draining. A second bit is about depersonalization, when people feel that they're not their normal selves. And lastly, it leads to an absent sense of personal accomplishment. And as I said, it affects all jobs which are stressful, some more than others, but particularly it's important for medicine and medical training to see what that means. So emotional exhaustion can be defined as that you feel really tired, overextended by your work. You can't do things effectively. It affects your relationships. It affects your outside work. It affects your friendships and work within the family. And there have been rather tragic instances in this country in the last few years. There have been rather tragic situations where young doctors who had been on call overnight and were driving home feeling tired and had crashed and then unfortunately died. So that exhaustion combined with physical and mental exhaustion can play a major role. The second component, as I mentioned earlier, is depersonalization, where you don't have any emotions, you're unfeeling, unempathetic, impersonal responses to interactions with patients and their carers. And thirdly, as I said, this poor sense of self-accomplishment. It needs to be differentiated from stress. Stress is about over-engagement, it's about overactive emotions, it's about hyperactivity and urgency, and can lead to anxiety disorder, whereas burnout is disengagement, blunted emotion, feeling helpless, feeling hopeless. Your motivation and hope disappear, and you feel detached and depressed. And quite often the reasons which have been described for burnout, it's about lack of control over workload. And I'll come back to that because that's quite an important aspect. across countries, then a lack of decision latitude. So your ability to make decisions kind of gets affected. Work is monotonous, same old, same old, same old. And work can be chaotic, so you can't really organize yourself. And particularly in healthcare, generally, quite often you have mundane routine work, which is interspersed with complex, urgent, emotionally demanding tasks. So if you're a surgeon, for example, you may be dealing with appendix, which might be fairly straightforward, a hernia. And then you might have very complicated abdominal surgery to perform with, teasing out malignancy or whatever. So there's a mixture, and it has impact on incomes, and particularly in countries where it's a publicly funded healthcare system, there are different pressures than if they're insurance funded or purely private. And then we know that personality traits such as perfectionism, wanting to feel in control, and competitiveness, they're all prized by medical schools at the time of admission. So what makes us ill is work, environmental factors, clinical factors, physicians, personal factors, and societal factors. And particularly for medical students, we also need to bear in mind is that 3/4 of psychiatric disorders in adulthood start below the age of 24. So half of them start below the age of 15. So by the time you reach 24, your chances of developing psychiatric disorders are pretty high. So that's an vulnerability that we need to be thinking about. And there are 3 stages of burnout. First is stress arousal, which is typified by difficulty in concentrating, memory lapses, irritability, feeling anxious, having poor sleep, palpitations, panic, loss of libido. Second stage is the period of energy conservation and maladaptive strategies. So you start to avoid work, you're constantly late, you withdraw socially, excessive sick leave, etc. And the final stage is exhaustion associated with depression and anxiety and suicidal ideation, apathy. And, one response is you disappear, you don't answer your pager, you don't answer your mobile phone, unexplained absences during the day, slowness in doing procedures, clerking patients, dictating letters, making decisions, bursts of temper, which has been described as clinic rage, shouting matches, reacting badly to real or imagined slights. And it can lead to rigidity. So one of the challenges, particularly in many branches of medicine, is tolerance of ambiguity, because patients don't always behave the way we expect them to behave. So same set of symptoms, they will respond in very different ways. They'll present in very different ways. If you're burning out and people around you see that you're burning out, junior colleagues or nurses find ways to avoid you, and they'll bypass you and go to somebody else. And obviously, this can lead to difficulty with exams and uncertainty about career choices, feeling disillusioned. You have this kind of failure of insight, which means that you reject constructive criticism, become very defensive, and keep counter-challenging things. So burnout can lead to medical errors, impaired professionalism, reduced patient satisfaction, staff turnover increases, and depression and suicidal ideation. I'm going to give you some key findings. And one of the interesting observations in this study was that depression rates and levels were highest during the first postgraduate year of training. And obviously, there are a whole host of other factors like family background, personality traits, etc. And this study was conducted in Australia. They studied training stress and work-related burnout and depressive symptoms. And they found that, if you assist junior doctors, trainees to manage workload demands and patient contact, this will have many beneficial effect on their work enthusiasm and mental health. And nearly a quarter in that survey reported having had thoughts of suicide in the previous 12 months. And thoughts were significantly higher in doctors compared to general population and in other professions. So almost twice as common. And in a systematic review, they found that, again, particularly for women, these risks were higher. Anesthetists, general practitioners, and psychiatrists appear to be on the highest risk. Similar findings emerged from America. American College of Surgeons did a survey. Only 1/3 of its members responded, but 6% reported suicidal ideation in the previous 12 months, which is between 1.5 and 3 times more common than general population. And what is really worrying is that only a quarter of these surgeons who had suicidal thoughts considered help, and 60% were really reluctant to seek help, and I'll come back to that. In 2008, we did a survey of burnout in a small industrial town in North India. These were all members of the Indian Medical Association. We used burnout inventory and GHQ-12. And to our surprise, we found that rates of burnout were very low in this sample. Now, there are two things that we need to bear in mind. One is that it may be 13 years ago, so things may well have changed. But also, at that time, what was very clear was that everybody in this sample was in private practice. So they could control who they saw, how many patients they saw, how long did they work, etc. And they had the power to control their workload. So there are two double binds, particularly for doctors and medical students. I mean, one is that in order to be a good doctor, you need to be able to relate to patients. So you need to be empathic, you need to be humane. And yet, at the same time, to survive emotionally, one needs to be detached. So you need to be professional. So you can't have it both ways. You can't keep a professional distance and be empathic. And the challenge in help seeking, and bearing in mind those 60% surgeons who did not consider seeking help, is partly about stigma. It's also about self-stigmatization. And you get concerned that it would affect your medical license, and there might be challenges in going in front of the Indian Medical Council or its equivalent, or General Medical Council, or American state registration, etc. And there are, we generally tend to self-diagnose as well, and I'll come back to that. But one of the other interesting things that I need you to bear in mind is that increasingly we're getting more and more protocol-driven approaches. So we're following algorithms, we're following guidelines. So that has major challenges, and I want to come back to that. So for doctors and medical students, I mean, you deal with physical and emotional distress 24 hours a day, and you keep giving emotionally. So who gives to you? You very rarely get positive feedback. Complaints are plenty, but lack of feedback. Quite often, you may be working in isolation with poor support. Long hours means that your family relationships are poor, work-life balance is disturbed, and you may have organizational challenges. So as I said earlier, that part of it is that perfectionism, part of it is that professionalism, maintaining that distance, but also increasingly around the globe, patient expectations are changing. And quite often you will see in clinics that patients come with printouts from the web, or somebody has told them that, you need drug A, B, rather than what the doctor is prescribing. So when I was president of the British Medical Association in 2018-19, we did a survey. We used Oldenburg burnout inventory, which assesses the two core dimensions: exhaustion and disengagement. And we got 4,300 usable responses. Now, that's not that many. And again, I think one of the things that you need to bear in mind in terms of online surveys is that quite often people who respond may not be entirely representative. So these are the people who may be suffering, so they may feel this is a way out to kind of report their concerns. 80% of the sample were at high or very high risk of burnout, with junior doctors most at risk. Just like the general population, a quarter had been diagnosed with a mental health condition at some point, and 7% in the last year. And if you were working longer hours, 51 or more hours per week, you were more likely to report that suffering. 90% of respondents said that their working, training, or studying environment had contributed to their condition. And men and older doctors were more likely to engage in self-prescription, self-medication, and using alcohol and drugs to cope with their condition. And 1/3 of the sample reported using alcohol and drugs to deal with that. So we followed that up with a qualitative survey. So we had 10 focus groups with 66 people randomly selected, representing all the variations in the original sample. And we came up with these kind of 5 factors. So there were systemic factors, which is certainly in the NHS, there's got a lot of understaffing and rota gaps, poor work-life balance, blame culture. Increasingly, as doctors, we're filling more and more forms rather than spending time with patients. And particularly for junior doctors, their jobs change every 4 months, 6 months. So the access to support services can be problematic. Occupational factors that, there are quite often you're faced with traumatic events. Quite often there's no debrief. How do you keep your skills up to date, rapidly evolving medical pharmaceutical landscape? Then there are interpersonal factors. And as I mentioned earlier, it's about stigma, fear of judgment, that if I report that I'm feeling unwell or I have a mental stress disorder, I may lose my license to practice. And then in many hospitals in this country, at least, you don't get time for a break. You don't have access to canteen or mess where you can get hot foods. You get crisps or cold drinks from machines. And, because of various reasons, you may be traveling long distances for work. And this general sense of feeling undervalued and increasing patient expectations and self-diagnosis can cause problems. So that can lead to all these things that I've already mentioned. At the same time, I'm going to report very rapidly from a GMC survey where they had responses in 2018, and there have been subsequent studies, roughly similar, 51,000 doctors in training and nearly 20,000 trainers across the United Kingdom. What they reported that a quarter of the doctors in training and over 1/5 of trainers told us that they were feeling burnt out, that they were often or always exhausted at the thought of another shift. And over half of trainees felt worn out at the end of each working day. 1/5 of doctors in training said that they felt short of sleep. And nearly half reported that they were working really long hours. And this meant that, almost 1/3 felt exhausted at the morning at the thought of another day at work. And this was consistent across the all the nations, 24% trainees in England, 21% in Northern Ireland, and Scotland, 23% in Wales, and similar kind of figures in among trainers. So we then, following on from the BMA survey, we decided to do a survey on medical students' health, and I'm just going to sort of quickly go through some of these findings. But in addition to the burnout inventory, we started using General Health Questionnaire 12 to measure common mental disorders like anxiety and depression and so on and so forth, bearing in mind GHQ 12 is a screening tool. It is not a diagnostic one. We were just trying to figure out what the percentage of the problems would be, and we used CAGE to assess alcohol use, collected basic demographic details, assuring confidentiality. We had 3,766 medical students from 12 countries. And I'm going to sort of just focus on, if you look at GHQ 12, the rates varied from 62% in India to 75% in Canada, 77% in England, 87% in Hong Kong. Disengagement, 95% in Hong Kong, and 95% exhaustion in Hong Kong. And again, you could argue that that's partly because of the political situation there, which may be contributing to that stress. And when we looked at, for example, in Morocco, there were only 47% scored above the cutoff point GHQ, but 93% were reporting exhaustion, and 99% in Paraguay were reporting exhaustion. So when we looked at alcohol, in Morocco, only 5%, but 28% were using cannabis to deal with stress. In Portugal, 10% were scored positive on CAGE. In Paraguay, it was 20%, but 79% in Paraguay and Portugal were using cannabis. Now, that is a reflection because cannabis has been decriminalized, so it's easily accessible and easily available. So when we looked at the medical student stressors, we divided them into 4 rough categories: financial, studies, relationships, and housing. Now, there are very clear cultural differences. For example, in England, only 24% reported pressure due to studies, whereas in Canada, it was 64%, but that may reflect the medical school in Canada, which takes more mature students. 98% of people in Hong Kong were reporting stress on relationships, whereas 59% in England were reporting stress related to housing, and in Paraguay, it was only 8%. In India, money on 18%, studies very low at 6%, relationships quite high at 69%, and housing at 42%. And this exam sample from India had 2 private medical schools and 2 government ones. And we then, as I said earlier, that we kind of went on to the second wave. Most of it was post-COVID. So one of these figures that we need to bear in mind. These are the countries with number of respondents. And this is the proportion of female. And by and large, you would see that in most countries, majority of the medical students are female now. And it also meant that, there are gender differences. And interestingly, in India, 78% scored, 78% of female students scored above the GHQ cutoff compared to 64% men, and 88% were disengaged female students and 85% men. And exhaustion, men were much more likely to be exhausted than women. Similarly, there were kind of differences in use of alcohol and cannabis. And Nepal had sort of 50-50, 50% female and 50% male students. And there was, again, levels of disengagement were much higher than compared to exhaustion. So when we looked at the stressors, there are academic stressors, which are across all years: increased scholastic workload, competition for scores and subsequent career choice, high-stake examinations, and too many tests, and there are other expectations. And one of the things that emerged in our qualitative survey in talking to medical students in the UK was that they felt that they were turning into technicians because medicine had become far too technical, and they'd come into medicine to look after patients, not to be technicians. And second thing that emerged with medical students from the UK sample was that a lot of teaching is done with simulation. So what they described to us was that, the patients that you're seeing in simulation labs and so on and so forth are actors. So they said that, students told us that at the back of our minds, we know that these individuals are actors. They're really not suffering. They're pretending to suffer. So there is a very clear disconnect between empathy. You can't generate empathy. And at the time, even if you want to, there are other challenges. In clinical years, medical students reported that, going from ward to ward, unfamiliar environment, variable type of patients, various type of hospitals, varying degree of supervision and teaching. And sometimes there are poor role models, and then there are administrative difficulties. And not surprisingly, when you go to medical school, you've left your school friends, you've left your family behind, you're in a hostel. So that loss of contact and forming new friendships can take some time and can create tension. Then there are peer expectations, feeling lonely, and it's very commonly loneliness is associated with depression and anxiety, and that can cause problems. And quite often, there are unrealistic expectations, both of the course, but also the people who run the course, their unrealistic expectations of medical students. And then there are familial, spiritual, financial pressures. And certainly, one of the things in the first wave of sample from India we picked up was that a lot of medical students had gone into medicine because that is what was expected of them. That's what their parents wanted to do. And there were parental expectations, particularly if they were doctors, that their children would use the same specialty so they could take over their clinics and hospitals and services. So certainly, this slide is very much a UK-based slide, but you can apply it anywhere. That there are organizational pressures. So at that level, government, although there are lots of regulatory pressures, and increasingly they're becoming much more difficult, certainly with regulatory bodies regularly visiting hospitals and clinics, and then pressures in the hospital and patients and management, which affects kind of teachers and senior people, which then pressure falls on trainees. So in a way, the maximum power is at this level. Trainees have the minimum power, but yet they do most of the work, and they do quite a lot of frontline work, which can be incredibly stressful. So what we need to do to manage burnout in medical students and doctors are three things. We need to work at personal level, we need to work at organizational level, and at a national governmental level. So resilience can be defined as the individual's ability to adapt to and manage stress and adversity. It's complex, it's multidimensional and dynamic, and some people don't like to use the term resilience for a number of reasons. But it is, how do you face fear, particularly for doctors and medical students? That moral compass is incredibly important. Religion and spirituality, what does that mean? How do you use that to support you? Social support, having good role models, physical fitness, brain fitness, and as we were hearing earlier, that you heard about physical and mental fitness early in this conference. So part of the challenge for all of us is to encourage self-care. We need to look after ourselves and our peers, be they medical students, be they colleagues, be they nurses, be they occupational therapists, be they social workers, whatever their expertise is. So valuing and maintaining one's mental health, recognizing ill health in colleagues and offering support if you know that they're struggling, understanding the difficulties colleagues face rather than being critical, and being alert in creating an inclusive environment. So if you are feeling stressed, if you're feeling exhausted, use your primary care physician before problems arise. Use support organizations. Create space for yourself and allow for colleagues to join you. Seek help early. Share problems with family, friends, colleagues. Admit your vulnerability. You are human, just like your patients. Identify and prioritize activities. Adapt a healthy, balanced lifestyle, good sleep, physical exercise, diet. Maintain good relationships and friendships for support. Use peer support system. Sense of humor, regular breaks, emotional intelligence. Find a voice through professional bodies. But more important than all of that, there is something that you know your strengths and you know your weaknesses. So try and build on your strengths and deal with your weaknesses. If you like music, playing or listening, do so. Reading, going for physical activity, yoga, meditation, whatever works for you. Whatever works for me may not work for you, but share that. So seek help early, know the sources of help, and have a right career. Particularly as a doctor, you need to create a portfolio of things you like, you enjoy, your specialty. But if you like teaching, put some teaching in your timetable so you can teach. It does not have to be attached to a medical school and teaching medical students. It could be teaching public, teaching the community, teaching religious leaders, a number of charitable activities, as we've heard from Avdesh. So you can have a mixture of research, clinical, teaching, management, medical politics, medical writing, entrepreneurial bits, and change something in your job portfolio every few years. So understand your mind, mindfulness training, strengths and weaknesses, develop self-compassion. Who are the people who will support you? Look at your lifestyle and make sure you get sleep. Organizations need to support avenues. They need to have access to occupational medicine, occupational health. They need to advertise these, and they need to make sure that these are confidential. They're fit for purpose. Certainly in the UK, there are two things which happen. One is Ballant groups, where junior doctors meet on a regular basis discussing cases, but within that, they also discuss issues about themselves. Schwartz rounds is an American concept which is broader. Along with doctors, you have nurses and other health professionals who can join and discuss cases. So recognize, the organizations must recognize and prioritize issues of well-being among doctors. They need to appreciate their workers and empower them, have wellness programs, wellness offices, wellness guardians, better communication, physical and emotional resources, coaching and mentorship. And the government must ensure that there's funding available for those activities, resources is accessible, training of regulatory bodies as to what they ought to be looking at, and research and evaluation of what's going on. And just to sort of draw this to a close, I'm going to highlight some of the recommendations that Health Education England made last year. There were 33 recommendations that suggested that every National Health Service organization should have a workforce well-being guardian, a well-being leader who reports to the guardian, and well-being training. And this is clearly important. I'm not going to go through each of those, but just to highlight that if there are concerns about suicide or attempted suicide, then these need to be independently examined and findings reported to hospital boards, making sure that the cultural and spiritual needs of staff and those learning in the NHS, be they nursing students, be they medical students, are protected. So to conclude, I think it's absolutely vital that we all need to look after ourselves if we're going to look after our patients well. And we need to seek confidential peer support if needed or possible. There's no need to be ashamed. We're all human beings. And this will make you a better doctor because you can understand then where the patient is coming from and what that means. So thanks very much for tuning in. And I'm very happy to take questions or comments. Thank you.
Thank you, sir. Thank you for such a enlightening and informative session. And I might sound slightly being selfish by using this opportunity of being a moderator of this session. And I would like to start with one question which is there in my mind since fairly a long time. You have very prominently highlighted the incidence, the rate and prevalence rate higher among medical students. We assume that being medical students, they are aware of these issues and challenges. But one area which is bothering me and would be bothering many other people who are interested in well-being is that the very low rate of help seeking in general population and more specifically among medical students. You have talked in your deliberation about the barriers, about the reasons for not seeking help. But I would like to utilize this opportunity to seek guidance from you that what should be done to generate or increase help seeking among medical students, because they are suffering from double stigma. Confessing, telling, they being on a role where they are health givers. They are the people who are responsible for making life better for others. But for their coming and seeking help for themselves is understandable. But we need to have, and I think the time has come wherein we should have some policies, programs. So I seek your advice and guidance on that.
Thank you. That's a very important question. And there are 3 or 4 things immediately spring to mind. I mean, one, you're absolutely right. It's about stigma. In general public, in medical students, if I say that, I'm feeling depressed, it's somehow not acceptable. But the fact that, people like Deepika Padukone came up and sort of said that she was feeling depressed, highlighted that anybody can be affected. And, there were people who were accusing her, why you have no reason to feel depressed because you're very rich and you have name. But the reality is that it can affect any of us. So making that leap in trying to encourage people that it's not, again, if you go back to Ramayana, there's a very clear family history of depression among Suryavanshis. So it's how we use that knowledge to destigmatize our teaching and learning. And also, I think one of the problems in mental health has been that mental health and physical health have been split apart. So we need to bring them together. And we know that, you would know from India that People quite often present with physical problems when they're feeling depressed or anxious. So we need to consider new models of healthcare, of teaching. It's absolutely critical that well-being and self-care is taught from day one of medical school. Not, teaching psychiatry from day one is absolutely critical, because otherwise you get 2 weeks of teaching in psychiatry in 4th year of medical school, by which time it's too late. So you need to make people aware that, mind affects body affects mind, and therefore there's nothing wrong in seeking help. And if you have confidential services, they can be less stigmatizing when they know that, if somebody's come to see me and they know that it's not going to go anywhere apart from with me, that makes it easier. So there are lots of steps that medical schools, regulators, and clinicians can take.
Right. Thank you, sir. Thank you very much. And now we have some questions from audience. And there's this question wherein it has been asked, as a young Indian, what guidance would you give us to take this initiative forward and spread the word of burnout amongst young medical and health professionals?
I think first step is to recognize that it's a problem. And quite often, people only look for things that they know are there. Mm-hmm. So making sure that, the research is widely distributed, disseminated, discussed. And then it's a responsibility, not only on medical schools, but also on teachers and on clinicians and policymakers to make sure that services are accessible. And that goes back to the point that you were making earlier about stigma in public. But that can only be reduced by innovative ways of looking at. I understand that in Gujarat, there is a dargah where people with mental illness go to pray. So they have now trained the religious leaders, and they've set up a clinic on the premises of the dargah. So now when people go in, nobody knows whether they're going in to pray or seek help. So we need to look at, and I think that's where India can be incredibly innovative and strong, because you can use spirituality, you can use religion, you can use other voluntary organizations to provide access, which is less stigmatizing. And that's, again, one advantage of digital psychiatry could be that, if there are things in place, then, you and I can have a conversation and nobody else needs to know. As far as your family is concerned and others concerned, you're working on your computer. You're not talking to a psychiatrist. So we need to be innovative and original, and that's incredibly important that we think outside the box.
Sir, I would like to share an experience which emerged out of adversity, especially during the lockdown, when due to COVID, there was lockdown and all that. So we, though we have a wellness club in our institute, I happen to be part of it, but due to this restriction of physical and social distancing and all that, we switched over to online mode, right? Wherein I was looking after a specific area of tobacco cessation and substance use, and the two among students. And it was a blessing in disguise that the amount of help seeking, when we were doing it in online on virtual mode, the privacy, the issue of other being known to others among that kind of took care of itself, and then help seeking increased. coupled with that, there would be other factors that they had now more time to look towards themselves. They have nowhere to go out.
Yeah. And you don't have to travel. You don't have to spend time traveling. Yeah.
But this give us this clue that since it's a highly stigmatized and all that, a program where anonymity, comfort of doing it without knowing, without getting in public, is something that can be looked at in terms of.
I mean, I think it's absolutely. I mean, in lots of countries, they had been doing it largely for geographical reasons, that people couldn't get to big cities to be, so they would record their symptoms or record a video and email it to the clinician hundreds of miles away.
Right.
But equally, I think it is that innovative bits are important, but confidentiality and privacy has to be absolutely critical. Now, at the moment, I don't know who else is in the room with you.
Right.
So I have to make absolutely sure that as a clinician, that you are confident that nobody else is listening in, nobody's going to run in and,
Right. So we need to take care of the confidentiality. That's true. And if that is ensured, I'm sure there will be more number of people who will come forward to seek help, because one very, very important thing which prevent people in general to seek help, and people who are specialists in health in particular, is that what if others get to know about me having a problem, right? So thank you, sir. There's one more question. Should there be a new curriculum included for all medical and science faculties, stressing on mechanism that can help cope with stress and burnout?
Yes, in short, but the question then is that, we keep adding things to the curriculum.
Time and all that.
So something has to shift. I mean, again, also globally, it's a big challenge that in some countries, medical schools are only 4 years. In others, they're 6 years. So how do we, at what level? And for me, I think it needs to go back to the school level, even before people get to medical school. Because as I said earlier, that, half of psychiatric disorders in adulthood start below the age of 15. So we need to make children. And I think that's, again, one of the strengths in India, that, you can look at those resources in schools and encourage children to be physically active, and be aware and use various training programs at that level. And it may be something that, in some universities, you get extra credits for doing certain courses. So for medical students, that may be one option, that if you've done a well-being and self-care course, you get extra points, so that, you kind of pass marks get shifted. So I think we really need to be very innovative about these things. And yes, I do feel that we need to introduce people the idea of how do you look after yourself when you're stressed and you've been on call for 36 hours. And there's still more demand that before you go home, you have to do this. And how do you look after yourself? How do you learn to say no? That, this is what I can manage and this is somebody else can do. And equally, I think increasingly in medicine, there is a challenge that we need to learn how to delegate certain things. Doctors don't have to do everything.
Right.
And again, that's a very interesting example in India, because quite often lots of things are done by people who are trained but may not have a medical background.
That's true, sir. Right. So before we end this session, I would like to read out a comment which is more of a compliment than a comment. So there's this participant who has written, sir, it's been such an informative session. Truly thank you for illuminating us. A big thank you to you.
Thank you.
Right, sir. And with this, I would again like to thank you for having you with us for such a informative session. And we look forward to your guidance and your help to take this program forward. Thank you. Thank you once again, sir. Thank you very much.
Thank you very much. Happy to help anytime. Namaskar.
Namaskar.